Good afternoon, everybody. For those of you who don't know, I'm Mark Gabay. I'm the theme lead for Health and Care Across the Life course. It's great to see so many of you here, and if you could and your bandwidth allows it, could you please leave your cameras on? Because I think it's nice to see people's faces rather than blank areas, he says, not having put his own camera on. But could you please mute if you can, unless you're wanting to speak. We will be voting at various times. And so I'm going to talk about that shortly. There's a lot to hear about today and lots of things to do at today's meeting, including lots of voting, because we're really keen to hear your views and which areas of our work you're particularly enthusiastic and interested in. The agenda is pretty packed, but we hope that it will be interesting and worthwhile. As I said, we will be voting at various times, and please bear with us. There's a few complications for that we'll talk through, but hopefully moving from one part of a device to the other will allow you to do that quite quickly once you get into it. There are questions in the voting about whether you believe that the topic that's being discussed is a high priority, a medium priority, or not a priority, and also of your own interest or that of your organization in that project. And Pallavi will talk a little bit more about that. So I now would like to introduce Dr. Pallavi Deshpande, who is our manager for the theme, along with the Person Centered Complex Care theme, which she manages alongside, so a very busy person, and she'll take us through the next part of the meeting.
Hi, good afternoon, everyone, and a warm welcome to all of you. I'm going to kickstart our meeting now.
For those who have not attended an ARC meeting before, especially if you are a member of the public, there is an opportunity for you to become a public advisor, an ARC public advisor, where you would be able to give your take or your opinion on research that is being supported by the ARC. In order for you to do this, you can connect with Selena Wallace. Her email address is being put in the chat box, as well as Ruth Ball, and they can help guide you. You can also go to the ARC Northwest Coast website, and the link is being put again in the chat function, where you can get more information about how to get involved. Just something that I have to say, just so that you know, everything discussed in this meeting is confidential. So let's start by meeting the team members. We have Professor Mark Gabay, who you've already heard from, who's the theme lead. Mark's also the director of the ARC Northwest Coast. Dr. Clarissa Giebel, who is the research fellow, and myself, Dr. Pallavi Deshpande, who's the theme manager of this particular theme, as well as person-centered complex care. On the 1st of this month, we welcome to the theme a new co-theme lead and deputy theme lead. Their role is to support the theme and ensure that our work program responds to regional community and provider priorities within a national context. Let's hear from them.
My name is Dr. Sakeju. I was a midwife for 35 years and a team leader and supervisor of midwives. And I was also the lead for the female genital mutilation, as well as equality and diversity. I've been volunteering for over 25 years, and I joined the clerk in 2015, and now the ARC. I applied for the co-lead role because I feel I can make a difference. I can be like between the public advisors and the researchers, make a partnership with the team and the PAs and the researchers. And also, I'll be like a champion as well for the public advisors, encouraging them to take part in projects as well as research. I feel I've got the skills that I can bring to the role. I've got interpersonal skill, writing skill, because I've written research before. I can review research paper, and also I can bring communities and publish together, setting up focus group as necessary. I feel that this role will be like working within a team, and that was no problem because I've managed a team before myself. So I'm willing to learn, I'm willing to share, and I'm willing to make constructive suggestions as well, and I'm willing to be challenging if necessary, and for my people to challenge me. I hope that it will not be easy to start with, but I hope that I'll be able to make a difference to the team. Thank you.
Hi, my name's Paul Moran. I'm one of the new public advisors. I'm relatively new to the public advisor role. However, over the past few months, I've really kind of thrown myself in and got involved in a number of the different working groups. I've met a lot of really nice people and feel really welcome. I felt as though I've kind of contributed quite a bit to the groups that I've been involved in. I work at the moment for Barclays Bank as a change manager. So what that involves is getting involved in between 20 or 30 projects at any one time, dipping in and out of those projects. And I really look at the kind of the quality of the projects and what they're looking to deliver. We look to deliver first-class things, first time, every time, of course, but, you know, I'm probably the person that asks those awkward questions and the ones that nobody else wants to ask, to make sure we kind of challenge and support the projects as much as I possibly can. What else do we do? So we also run a kids boxing gym in Old Swan. We take kids from kind of 7 years of age and we go right up to adulthood. We look to kind of improve their skills in amateur boxing, but also kind of, you know, a wider thing to promote their physical and mental health is really important to us. We've also got a lot of experience with different things, looking after kind of elderly relatives, looking after relatives that have got mental health conditions. So I feel as though I can bring quite a lot to the group, and really looking forward to finding out a little bit more about the work stream and also meeting everybody over the next few months. Thanks very much. Speak soon. Bye.
Ever since the ARC Northwest Coast started up in November 2019, there's been a lot of progress within the theme. About 56 applications were made to the theme in the form of scoping forms, projects, fellowships, internships, and even PhD studentships. 50 of these went towards grant applications and 20 were successful. Today, we have 3 completed projects within the theme. It's also very important to mention that there are some projects that we're working on which are part of international collaborations, and that's a really big part of our theme as well. With respect to publications, we have about 37 articles published and more than 15 articles have been submitted or are in preparation. Now, again, since November 2019, we have engaged with about 36 member organizations. It's important to mention that we've also engaged with third sector organizations that are non-members as well, and they have contributed largely to our theme. As you know, the ARC works really closely with the public, and this theme has been associated with about 23 public advisors since November 2019.
Hi, so many of you will have been at the theme meeting at December's ArcFest, and if you do, you'd have been on one of the round tables we had, the World Cafe breakout rooms, which would have been round tables had a meeting face to face, where we talked about 3 proposals that we wanted feedback from colleagues about. The first was from Dr. Clarissa Giebel, and you were sent some information about this yesterday before you came to the meeting, just to remind you of what was discussed, or if you weren't here, there's a very brief summary. And that's looking at research into care homes. And what came out of the World Cafe was the idea that we should be prioritizing work looking into the mental health of staff and carers as involved in care homes as a result of the pandemic, in particular. So you'll be voting on that shortly, and we would be interested in whether you think that's a priority project for us, and also whether you'd be interested in taking part. Then Dr. Jaideokar from Cheshire Wirral Partnership presented work he was planning on developing a data collection instrument for physical health amongst those with learning disabilities that would be used across primary care and secondary care, and something that they had been developing with his team, and he wanted to get some support to evaluate that more widely and see how it could be more widespread to be used by GPs and others when they see patients with learning disabilities, to give a more processed way to assessing their physical health needs. And finally, but by no means least, Professor Rhiannon Corcoran was presenting the work that she'd been planning on developing ways to think about mental health in communities after the pandemic, and how we might develop with those communities ways that community members could support the mental health and well-being of their neighbours and others living within the community, and putting forward a group to develop a large grant to apply for funding from the NIHR for that. So Pallavi will now explain what we're going to do about the voting options you have, because if you remember on the day, the voting didn't work the way it was intended to. I think I was one of the few people that managed to vote, and many of you tried but failed for technical reasons. So we're running it again today.
Hi, everyone again. So my colleagues have put in the link in the chat function. So if you can just copy and paste that link into your web browser. If you click on it, it doesn't work. So please just copy and paste. The first question you'll see is, what is your name and organization? If you could put in those details, and that's really important for us, because when you vote, and especially if you're keen on working alongside us, we can easily identify you and get in touch with you. So I'll just give you maybe about half a minute or so just to put in those details. Thank you.
Pallavi, it may be easier if you came off sharing, then people could get at their screen to go into their web browser.
I could stop sharing.
Because certainly on my computer, I can't get behind
You can't
it to
do
get to
that.
my
Okay.
web browser.
Okay.
Thank you.
Okay.
Now I can see my screen and put it in.
Sure. Okay, so hopefully everyone's had a chance to put in their details. I will be moving on to the actual voting. So I do have a screen here as a presentation, but if I put that on, you won't be able to see your web browser. So I'm just going to continue and take you through what the questions are. So you can see that the first question hopefully you can see that. The first question is based on the research in care homes, Clarissa's work. How would you prioritize this outline proposal for the ARC? Give it a few minutes, still moving. Okay, so we've got about 65% who think it's high, and about 35 who thinks it's medium. I will move on to the next question if that's okay, considering the time. The next question is on the same topic. Would you or your organization be interested in participating in this project? Okay, so about 70% yes and about 30% no. I'll move on to the next question. Research in care homes again. Which is your priority area? Mental health of staff, or impact on residents, or none of the above? So you've got about 50% that says impact on residents. Mental health of staff is about 35%, and none of the above is about 15%. Sorry, just changed. That's why it may not come up to 100%. Okay, so the next topic is the physical health assessment in people with learning disabilities. How would you prioritize this outline proposal? Okay, so we have about 53% high, 36% medium, and 10% low, and there's 3% who say it's not a priority. On the same topic, would you or your organization be interested in participating in this project? It's about 50% for both, really. It's yeah. Move on to the next. Post-COVID and mental health, how would you prioritize this outline proposal? Okay, so we've got about 10% medium, and the rest is high. That's quite good. And then would you or your organization be interested in participating in this project? Okay. So about 75% is yes and 25% no. Thank you for that. Oh, sorry, excuse me, sorry. Sorry, everything just recorded. Sorry about that. I'll just share my screen again.
We're going to move on to some project updates now. We will be doing some polling. So when you need to do that, my colleagues will be putting the link in the chat function.
Hi, my name is Clarissa Giebel and I'm a research fellow in the HaCAL team. Today I'm going to share with you an overview of our ongoing LMIC research. When we talk about LMIC, we mean lower and middle income countries. So each year the World Bank Group reclassifies countries into whether they belong into the lower group, lower middle, upper middle, or high income group countries. And particularly our ongoing work is with Colombia, Uganda, and India, as you can see on this map here. So one of our first projects, which started before the pandemic, was in 2019 with Colombia and with collaborators in Medellin. And we were interested in looking at the unmet needs and the health inequalities in dementia care in Colombia. So we know that mental health care and service usage is not adequate in many LMICs across the world. So we don't know a lot, though, about dementia care specifically. So we wanted to understand whether there were particular barriers that people are facing when they are trying to get a diagnosis or when they're trying to access community-based care services. So what our collaborators did was we started data collection in 2019, and the aim was to conduct 40 interviews with people with dementia and carers to really try and understand these potential barriers in care. Sadly, COVID has put a hold on this last year, but late last year and early this year, we were able to complete the data collection. So now our collaborators are translating those transcripts of those interviews into English, and then we will jointly analyze them. Another project which was made possible because of the pandemic was working together with Uganda and specifically the HaCAL. And the aim of this project was to understand the impact of the COVID-19 public health restrictions on the lives of older adults in Uganda. So our collaborators conducted 30 interviews with older adults there. And what was really striking, obviously these transcripts were again translated into English, and what was really striking when reading through those transcripts and analyzing them last year was the sheer difference in impact that restrictions seem to have on the lives of older people there, many of which are incredibly disadvantaged and live in quite rural areas as well, compared to older adults, say, here in the UK and Germany and the Netherlands. So some of those themes that came out across those interviews was the sheer economic impacts and the lack of access to basic necessities, which include food, medication, but also healthcare. The social impacts were really important as well, because most of older people in Uganda are very religious. They were really impacted by the fact that they weren't able to attend their church and religious ceremonies anymore, and burials, particularly as a result of COVID. Also, something that actually made headline news was violent reinforcement of restrictions in Uganda. So there was a 7 p.m. curfew, and many guards enforced this with heavy violence, which had a huge impact on older adults there. The sheer anxiety they were facing in being out that late, although they had to walk to get to the nearest hospital if they needed any emergency care, for example. And just to kind of illustrate these impacts with a couple of quotes, there are many, many more, but it's just to kind of highlight many of the people that we were speaking to. They were producing some extra food in their garden to then sell outside their house, for example, but because of COVID, no one was coming past the house anymore, so they had a lack of income. And also, I think the second quote is quite intense in that, so they were saying the price for food is now so high, so as a result, we can no longer afford 2 meals a day, so we end up eating one. So if you want to read more about it, it's published, and I'm happy to send you the paper as well if you fancy another read of this. Another study, which only started last month, and we wanted to link up with different LMICs to compare the impact of COVID and its restrictions on the mental health of older adults in LMICs. Now, to date, there appears to be no evidence yet out there, particularly when we compare it across different cultural and geographical settings. So we're now working together with Uganda, Colombia, and India, and it's quite a large data collection involved as part of this. So in each country, this month and next month, as soon as ethics are cleared, each country will conduct up to 30 interviews with older adults, people with dementia, and carers. So we'll have a total of 90 baseline interviews. And each country will also conduct one focus group with health and social care professionals. And then 3 months later, we will conduct again in each country 15 interviews, so a smaller subsample of the original ones. And we really want to understand the long-term psychological impact. So stay tuned. We're just starting data collection in the next couple of weeks. And last but not least, a much bigger project, a 3-year project. We were lucky to be funded by the ESRC. And we are trying to understand and address the mental health of older adults in Colombia. But not only looking at the impact of COVID as a stressful life event, but particularly with Colombia and its political history, we want to understand how political violence, which has really badly affected this country, what's the impact of that on the mental health of older adults living in Colombia. And we will be conducting a lot of separate elements as part of this 3-year project. One of the main things that we will start with is a mental health needs assessment, both quantitatively and qualitatively. Then, via co-production, we will develop a community-based mental health intervention, which we will then test out in the community. So, as I said, lots of this is still work in progress, so do stay tuned. We will update you about this as we go along.
Thank you. And of course, the relevance of...
Sorry.
Yep. No, carry on.
Okay.
The Communities Network. The first question we have for you is whether we should call it NocToc Network or the Nocticon. And there'll be a vote at the end, which you can say, yes, you like one or the other or neither. So this is still active, but I thought I'd give you a brief update as to where we are with it. And so let me tell you a bit more about where we're up to with the network. So nationally, the national network is still meeting. We haven't heard, as far as I'm aware, from the ESRC Coastal Health Inequalities Research Centre bid that was led by Plymouth University, but clearly if that comes off, there'll be a lot of work to do growing from that for this region and our ARC. And as I said, we're still meeting as a group of national ARCs with coastal areas about developing external grant proposals. With the NocToc network, or Nocticon, this is now spreading, and we have now participants joining us from Cumbria, from Barrow, etc., through Fylde, Blackpool, and down south towards Wirral and the Wirral Peninsula and Cheshire. So the things we've been discussing have been coastline initiatives, and these include beach schools, and we've had some meetings with colleagues from Edge Hill about their education initiative there. There's also the Eden North project that is fundraising to build an Eden North seashells in Morecambe, and the work that's going alongside that. There are also projects happening in Barrow and in that area around using the coast as a facility for health and fitness and regeneration and health. And these are a multi-generational focus, is also being discussed. The other topics that we've been looking at in particular are regeneration and economic recovery projects in coastal towns and communities, looking at housing, particularly the rented sector, HMOs and what happens with the homeless in these areas. And then another question we've been looking at in some detail is COVID neighbourhood volunteer hubs in these towns and communities, and what's going to happen as the pandemic starts to fade away. How do we maintain that community volunteering and that focus of effort, and what should that be on? And one of the groups you're going to be joining very shortly will be looking at the post-pandemic project for this theme more widely, and with a particular focus on mental health support and prevention.
Okay, so we do have some, just to mention that this presentations from the ArcFest, which we couldn't really showcase at that time. We do have some voting next, but considering the fact that I have to stop sharing, we'll do the voting at the end of this particular project update, if that's okay. So that's the voting. I'll just move to the next.
Good day, everyone. My name is Kimberly Lazo, and I am a research associate from the Implementation and Capacity Building team based in UCLan. I am here today to talk to you about our project, which is called Mouth Care Matters, Exploring Promotion of Oral Care in Care Homes. We know that people living in care homes are at greater risk of oral health problems. There is a high prevalence of poor oral health and hygiene in care homes. Residents often have a difficulty in carrying out their own mouth care, and therefore they often rely on care home staff to do this for them. However, research suggests that carers oftentimes do not have the knowledge, skills, and confidence to deliver adequate mouth care to residents due to several reasons. It could be because of organizational related factors such as workload management, improper documentation, oral care not being a priority in the care plans, or staff not being trained during induction to properly look after people's mouths. It could also be external environmental factors such as the lack of infrastructure and resources to carry out mouth care within the care homes, and carers having their own perception of what oral care is, which can influence how they deliver it to residents. More importantly, there are social inequalities that exist within various localities that contribute to poorer access to external dental care, lack of resources, as well as higher staff turnover, resulting in inadequate support for the residents. Whatever the reasons may be, the current COVID-19 pandemic further complicated the situation due to the increased workload capacity to perform more important tasks, which pushed oral care down the priority list. This is in addition to the need for additional protective equipment, social distancing safety measures, and the reduced access to professional dental treatment. In order to address these barriers, oral care training programs with multiple educational components were recommended to sustain an effective oral care practice within care homes. As part of a national initiative to promote early intervention in oral care, Public Health England initiated the Mouth Care Matters program, which provides educational training to care home staff to make sure that all residents in care home have equal access to excellent mouth and dental care. This program is commissioned by NHS England and NHS Improvement in collaboration with local authorities in Cheshire and Merseyside, and its overall aim is to reduce oral health inequalities as well as improve access and equity of dental provision. So before COVID, Mouth Care Matters has been delivered in 9 local areas. The bespoke training program was co-produced with the care homes and local councils, and a good practice guide was developed and published to guide the program. This was delivered face-to-face, but because of COVID, the delivery had to be paused. More recently, the Mouth Care Matters delivery has switched to online virtual training sessions, and these are now readily available to the participating carers through the Manchester Training Hub. Given the national priority to improve the standard of daily mouth care, it is vital to understand the role of carers and how they deliver oral care for residents in care homes. Although most programs report some improvement in staff knowledge, they are inconclusive in terms of its impact in residents' oral health. To address this, we are currently undertaking a program of work within the ARC in collaboration with Public Health England, local commissioners, local councillors, and public advisors, where we are conducting a series of co-production activities that will help us identify which implementation approaches of Mouth Care Matters were effective, particularly those that contributed to changes in attitudes of residents and staff relative to improving oral care practices. One of the key things that we are doing is a systematic review that explores the barriers and facilitators on the implementation of oral care in care homes. We have also received a small amount of funding to pilot an initial evaluation of Mouth Care Matters in local councils who have already received training both in face-to-face and digital settings, where we are co-producing an interview topic guide that captures the challenges brought about by COVID-19, including the changes to the way oral care is being delivered. This program of work will inform an application to a larger NIHR program grant that will cover Cheshire and Merseyside and evaluate the online delivery of Mouth Care Matters as a result of COVID-19. So to summarize, this program of work tackles a very important problem that is oftentimes neglected within the care home settings. The provision of good mouth care should be prioritized because research has already proven that people with good oral health can stay independent for longer and can recover from episodes of frailty more quickly if they are able to eat and drink properly. The ARC can offer support in evaluating the implementation and delivery of Mouth Care Matters and how they are impacting not only the overall oral health of their residents, but also in the change of knowledge, behavior, and attitudes of carers towards delivering oral care. Thank you very much for listening, and we look forward to hearing your thoughts about our project.
So we have some voting after this again, but I'm just going to come back to it later if that's okay. So this is the next.
My name is Antoinette Davey. I'm the project manager for this ESME2 grant, which is funded by NIHR, HS&DR, and it's looking at the effectiveness and cost effectiveness of community perinatal mental health services. And it's being led by University of Exeter, King's College London, and University of Liverpool. There are 4 main aims of this grant, which correspond to 4 work packages. But generally, the aim of the grant is to develop a topology and understanding of what services look like across England, to assess existing measures used to assess quality of mother and infant interactions, which could be used by the community perinatal mental health teams, to better understand what types of these teams are most effective in improving mother and infant outcomes and in what circumstances using a realist methodology approach. And finally, using the national NHS datasets to investigate the effectiveness and cost effectiveness of these teams in improving access and outcomes. So the study we would like to get adopted by the ARC Northwest is Work Package 3, which is using the realist methodology to provide evidence around which types of these community perinatal mental health teams are most effective in improving mother and infant outcomes and in which circumstances. So we're interviewing up to 250 individuals across 10 services in England. And these include women who have recently accessed community perinatal mental health teams. They're significant sources of support and 50 staff members of varying staffing roles within the teams. And due to COVID, we're also asking the following questions around the impact of COVID on both the service delivery as well as the experience of care during this time. And we're asking what makes these perinatal mental health services resilient to public health emergencies for future lessons. In terms of recruitment, we are recruiting a range of mums across different diverse groups who are accessing these services. And in order to do that, we're working both closely with our patient advisory group and local charities to develop the most effective way of recruiting the range of families we want to include in our study, so that we can ensure that voices across these different populations are included in our results. So why should the Northwest ARC adopt ESME2? Well, we are recruiting in your area, as already mentioned. We have 3 services who are currently in the process of recruiting mums. We already have an impact on policy. We work very closely with NHS England perinatal mental health teams, providing them preliminary results of our interviews. And we develop policy briefs for NHS England, as well as responding to a House of Lords inquiry last year around the use of digital technology in service delivery. We're currently adopted by Penn ARC and South London ARC, which is the local ARCs for University of Exeter and King's College London. And we don't need any additional resources from the ARC Northwest. We believe that being adopted by all the ARCs, we will widen our dissemination and impact of this research. Thank you very much.
Okay, so I'm going to stop sharing, and if we could go back to the voting, if that's okay.
Yeah, I'll just pop in here. So
Sure.
just to update you, my presentation was one that unfortunately didn't happen at the ArcFest back in December. We've carried on meeting since then, and unfortunately the ESRC application was widely welcomed but wasn't successful. And we got lots of feedback, and we're continuing to narrow down our focus. But it's really just whether you believe that the idea of having a group that focuses on the needs of coastal seaside communities and towns is important and worthwhile for something the ARC to pursue. And in fact, the Chief Medical Officer is producing his annual report this year on coastal health, which I didn't mention in that report. And another item of information is that one of the expectations of ARCs is that we do, wherever possible, collaborate with national studies where they're relevant, but we wanted to check that with you, that you felt this was sufficiently relevant to our population to make it something we would be wanting to work with.
Okay, so thanks for voting. We've got about 55% for NOSTOC network, and about 20% for Nosticon, and just moving all over the screen. We've got about 30% neither. So we'll just move on to the next one, which is the Mount Care Matters. Would you prioritize this outline proposal for the ARC? I do understand that some people cannot access the website and are putting their votes in the chat. That's not a problem. I'll take everything together and maybe send out an email with the results, or we'll showcase it at the ArcFest in April. So we've got about 58%, let me start low, is about 8%, medium is about 56, high is about 33, and the rest is not a priority. Would you or your organization be interested in participating in this project? Okay, so I've got about 30% says yes, and the rest of them say no. Thanks for that. I'll move on to the next one, which is the ESMI2 project. But still moving. It's about 14% low, about 47% medium, and the rest is high. And would you or your organization be interested in participating in this project? It's about 25% yes and 75% no. Right. Okay. Let's keep on moving. I'm just going to share my screen so we can continue.
Next, we're going to have a presentation by our PhD students associated with the theme.
My name is Pippa Atkinson, and my PhD topic is how the revised UNICEF UK Baby-Friendly Initiative Standards influence the experiences of women, parents and infants who are socially and economically disadvantaged. I'm planning to undertake a longitudinal qualitative study of women parents' experiences using a narrative inquiry approach. The study objectives are to explore the experiences and perceptions of these women and their families in relation to the infant feeding support they have received over time. And by over time, I mean from the antenatal period until after they've had their baby. To determine how infant feeding support is communicated and to establish whether these mothers and their families have specific requirements in relation to the way infant feeding messages are communicated to them, and to develop vignettes which could be used during staff training to improve the way in which infant feeding messages are communicated to these women and their families.
Hi everyone, I'm Thais and I'm studying at the University of Liverpool. My project is looking into the facilitators and barriers to engaging with community support services in dementia care. There are an estimated 850,000 people living with dementia in the UK, and many people living with dementia and their informal carers rely on community support services to live well in their communities. These services are non-clinical in nature and can, for example, include peer support groups or respite care. The COVID-19 pandemic has compelled fundamental changes in how community support services are delivered. Some forms of support have and are reactively adapting to provide some sort of remote support. However, little is known how these community support services have adapted. So through a mixed methods approach, we're looking into what types of services are available, how they are delivered, and who has access to them during the COVID-19 pandemic. Thank you.
Hi, I'm Sean, and I'm based in the Department of Health Service Research at the University of Liverpool. This PhD is looking at how carers and communities are or could be involved in shaping social prescribing activities in areas of socioeconomic disadvantage across the North West Coast. Recently, we've seen renewed interest in the utilisation of community resources as a way of supporting individual and public health via social prescribing. Yet despite this, approaches to social prescribing vary and current evidence doesn't give us a full understanding of what works for who and why. This PhD aims to investigate how social prescribing works for one group of people that we know can be at greater risk of developing ill health, but seem to be missing from the social prescribing literature: informal caregivers. The research will use qualitative methods to address the following questions. What do carers living in deprived areas need from their local community, and how does this relate to social prescribing? What are the facilitators of and barriers to social prescribing programmes specifically for carers? And what impact does social prescribing have on carers, communities, and health inequalities?
Hello everyone, it's great to be able to introduce myself and meet everyone, even if it does have to be virtually for now. I'm Courtney Franklin, a PhD student at the University of Liverpool. I have a background in mathematics and medical statistics, and I'm really excited to be able to have this opportunity to undergo public health research. My research title is Addressing Inequalities in Childhood Febrile Illness Associated with Pediatric Emergency Department Attendance in Liverpool, and I'm fortunate enough to have the support of 3 supervisors, Professor David Taylor Robinson, Professor Ennerton Carroll, and Professor Bernie Carter. As most of us are aware, emergency department attendance continue to increase, especially in disadvantaged cities such as Liverpool, and a significant proportion of these can be for self-limiting conditions. Paediatric ED attendances have had an especially dramatic increase, of which febrile illness accounts for around 10% of these attendances. This project aims to look at how childhood socioeconomic conditions and other key exposures influence important child health outcomes from febrile illness due to differences in pathways for febrile illness, with the sole outcome of helping to contribute to a more equitable healthcare system and in turn reduce the burden on the NHS.
Hi everyone, I'm Aaron. I'm a PhD student at Lancaster University. My project will be looking at what it means to age well with bipolar disorder. The project aims to better understand the preferences, priorities and presenting needs of older adults with bipolar disorder to reduce the inadequate and unsuitable care that this group currently receives. The project will consist of 2 studies. So study 1 will involve photo elicitation, in which participants are given cameras and asked to take photographs of aspects of their life which they believe represent them aging well or not aging well with bipolar disorder, and these photographs will then be used as prompts for discussion in individual interviews and then explored further. Study 2 will involve biographical narrative interviewing, and those interviews will be used to explore people's experiences of living with bipolar disorder throughout their lives and to understand how people's needs change with bipolar disorder in later life. This information can be used to optimise person-centred care and reduce the health inequalities that this group currently faces. That's all from me, so thanks a lot and hopefully speak to you soon.
Hi, I'm Andrew Riley. I'm going to be working with Nevin Williams, Clarissa Giebel and Matthew Harris to produce a mixed methods process evaluation of a community health worker scheme in Halton and Warrington. In this scheme, a small cohort of community health workers will be recruited to work alongside existing healthcare and social care providers as a bridge between services and community. They will be assigned a fixed number of households, each of which they will visit once a month, regardless of expressed demand or need. The research questions we're trying to answer are whether this system is effective in supporting vulnerable groups in UK populations, and whether they can work effectively alongside existing healthcare and social care teams. I'll be collecting both quantitative and qualitative data to describe the recruitment of the community health workers and other features of the scheme's implementation, as well as about stakeholder experience, the study context, and broader observational data for comparison with control sites and similar schemes taking place elsewhere in the country.
We'll move on to presentations by our interns.
Hello, my name is Malaika Rahman Amin and I'm a Research Evidence Manager at Alzheimer Society. So I'm an unusual ARC intern in that I'm not from a clinical background. I work in the third sector and my role involves feeding research evidence into our policy and campaigning activity. Now my project will focus on effective dementia education and training for domiciliary staff. So that's professional paid home care workers who might support people with dementia in their own home. Now, why is this important? Surveys and YouGov polls have told us that the vast majority of people would want to live in their own home for as long as possible if they were diagnosed with dementia. Professional home care staff play a vital role in the support structure of people with dementia living in the community. They support with medication, washing, eating, and making trips into the community amongst other things. And because home care staff work so closely with people with dementia and their families, they're well placed to identify changes in a person's condition and behaviour, and they can help reduce the impact of symptoms by providing person-centred care and also signposting to places that can provide information and support in the community. Yet previous investigations by Alzheimer's Society have found that 1 in 3 home care workers have no dementia training, and only 2% of people affected by dementia say that home care workers have enough dementia training. In a survey of around 1,000 people affected by dementia that was undertaken in 2016, 49% did not think home care workers had sufficient dementia training. And 38% thought that they did not know how to treat people with dementia with understanding and dignity. In a separate survey of 739 care home workers, 86% of home care workers believed that dementia training would actually help them provide better care. So good quality training and education is hugely important in enabling quality dementia care. Now, much work has been done by the researcher community to understand this issue. In 2016, researchers from the University of Bradford and University of Leeds came together to understand what works when it comes to dementia training. In this project, they worked to identify the programs and approaches that lead to the best outcomes for people affected by dementia and their families. So my project will involve analysing this paper entitled Effective Dementia Education and Training for the Health and Social Care Workforce, a systematic review of the literature. And the research was led by Professor Claire Sir and Professor Jan Oyebodes with their colleagues. With the COVID pandemic shining a light on the need for social care reform, I think that an internship will provide an exciting opportunity to examine existing syntheses of research and to help use that knowledge to help influence policy and practice. Thank you for listening, and if you have any further questions, here's my email address.
Hello everyone, my name's Thomas Faulkner. I'm a research intern working with Clarissa Giebel, and my project will be looking at the support given to people with young onset dementia and exploring the perspectives of the staff members of those services to find out what is working and what is not working in those areas. So a little bit about me. I've worked for 5 years in a memory clinic as an assistant psychologist in Southport. And my work has predominantly been post-diagnostic support and care support for people with dementia. And that support has been a little bit more in depth than what you would usually have in clinical settings. So I've been able to gain quite a good insight of people's experiences and challenges that they've faced in the diagnostic and the post-diagnostic journey. And that has inspired me really to want to look more into the experience of people with young onset dementia. Partly my own experience has been that it's a little bit more challenging for people to navigate these services, and maybe they're not adequately adapted towards it. So what is young onset dementia? It's generally considered to be people under 65 years old, around 4% of the dementia population, and it's a bit more of a complex picture really in regards to socio-economic impacts. People might lose their jobs, people might lose their driving licence, and there might be younger carers involved who have to take up new roles really. Navigating services again is a much more difficult thing sometimes. The diagnosis takes twice as long often, and there's more stigma, less informed people involved in regards to what this particular complex picture of young onset dementia really. So and with the rare dementias as well, which are more common under 65s, services may not be as adequately well informed on how to provide effective support for those people. So the project I want to do is really to look into that. There's not that much research out there looking into the staff side, asking the questions on what can we do better. And I have good links with secondary services, with local charities in Sefton, and with a Care Navigator service. So that's where I'm going to start a bit of a thematic analysis with interviews, and I've got 2 public advisors helping me with design and implementation. And then in the future, I want to apply for a PhD to try and expand on that even more, looking at the GP practices and the care homes and the hospitals, and just looking at the whole experience of a person with young onset dementia and whether or not there are gaps and whether there are differences in that experience.
We'll now move on to our mini pitches session. The speakers are Nadia Van Ginniken, Joe Rylands, and Craig Murray.
Hello, I'm Nadia Van Ginniken. I'm a GP and clinical lecturer at the University of Liverpool. I'd like to put forward to you a proposal to involve some public advisors in the fellowship application that I'm developing at the moment. I've already involved quite a few public advisors and communities in this, and would like to ask for more formal support. So the issue is that so far I've put forward several proposals for social prescribing to understand the wheres and hows and what's happening on the ground. And now this fellowship takes this forward, especially from the systematic review that's currently that we're currently undertaking, looking at motivational interventions to help people with taking up and sticking with either social prescribing or well-being activities. So social prescribing is that linking process of helping patients link to what they want to link with that can help with their well-being. And the well-being initiatives might be there as a standalone without that linking process, and are either things to help promote their happiness and their sense of purpose, and they can address the practical support of addressing housing, safety, and financial burdens, which contribute to poor well-being. So this, from the scoping exercises we've done so far, it's emerged that, you know, the ethnic minorities are a seldom heard group, don't access mental health services easily or readily, and often they're inappropriate, and that's why, and also have difficulties with accessing and feeling trust with primary care. So we feel that an innovative community-based approach to helping them and engaging them might work better. So we'd like some support to help co-develop these interventions. We've got support from 3 sites so far, and there may be more coming forward. The systematic review will inform the development of the intervention. So phase 1 will be this development, where the systematic review will inform a toolbox of different psychological interventions to help with that behavior change aspect. But this will also include a much wider package to address the barriers that people experience with engagement. So that might be practical barriers, structural barriers, like not having access to these, or language, cultural barriers, etc., or appropriateness issues, and also barriers of their own personal barriers to this stigma, or practical things like finance or travel or whatever. So we aim to figure out what the whole package can be, and then present it to demonstration sites for them to choose what they think will be appropriate for their communities. The next, once the fellowship is underway, we would reapply then for more public advisors. So this is a time-limited request over 6 months for 2 public advisors from ARC to be involved in the overview of the whole project proposal. And we'll also be applying for 4 other advisors from the Research Development Service, Research Design Service, where we'd recruit other public advisors from each of the demonstration sites to help with the feasibility of developing the intervention in those sites. Thank you for listening, and please share your comments and views.
Hi, my name is Joe Rylands. I'm an academic and training GP in Liverpool. I'd just like to quickly run over our plans for a low carbohydrate program for people with type 2 diabetes in Liverpool. Everything is focused on COVID at the minute, and obviously that's incredibly important, but continuing in the background and worsened by COVID will be the same problems that we were facing before the pandemic. I would argue the most clinically important of these is type 2 diabetes, because it has a huge burden on the population. That burden has not been reduced over the last 2 years, despite multiple public health interventions, and that burden is disproportionately on people who are economically disadvantaged, both in terms of how many people get it and in terms of outcomes. Low carbohydrates have been an idea used in type 2 diabetes for a long time. Carbohydrates are complex molecules of sugar. Diabetes is a problem of not being able to metabolize sugar properly. So the theory is that you reduce the carbohydrate, you therefore reduce the load on the body, which improves outcomes. If it's that obvious, why isn't everyone using it? So part of that comes from different levels of evidence. So multiple reviews have concluded that it's not. Multiple systematic reviews have concluded that it shouldn't be advised as a mainstay of treatment. And the problem with this is that of adherence. So short term, it overwhelmingly shows that low carbohydrate diets outperform low fat diets, and they outperform traditional treatment. The problem is getting people to adhere to it, because over time it's a very difficult thing to stick to. We also know that the basis of why people get diabetes is not an individual diet problem, it's a systemic societal problem. And with all of these behavioral changes and individual changes comes the uneasiness that we are not addressing this in an equitable way, which is why I have the faces of Margaret Whitehead and Jenny Popey watching over. So what we're proposing to do is to translate a very successful program by the Unwins in Southport, who have for 6 years gone against this idea that it can't be adhered to. The way that they've done that is using a community-owned basis and educating people and trying to encourage adherence with hope, motivational techniques, and ownership. So what we're planning to do is translate that model by using health trainers who have used low carbohydrate diets for themselves, have type 2 diabetes, and they'll be supported by the local GPs. We're going to gather the experiences of patients going through this program. But one of our key concerns is obviously about health inequalities and trying to get a diversity of patients involved in the program and sticking with the program. That's kind of what I would like your help with, is ways that you think that we could improve that. So we're doing some patient participation work with some of the diverse groups in central Liverpool. But we have concerns obviously about currently doing it during COVID. That will involve doing it over Zoom. There is technology poverty in the area and ways that we could possibly work around that. And then even if it's just on a community basis, when that's safe to do so, how people would recommend that we encourage it. Yeah, I'd be really interested in your feedback. Thank you very much.
Hello, my name's Craig Murray. I'm a lecturer in orthoptics at the University of Liverpool, and I'm going to be talking about my potential PhD proposal in eye movements and visual function and the detection of mild cognitive impairment and Alzheimer's disease. Specifically, the aim of my project proposal is to determine whether measures of visual function, retinal structures, and saccadic eye movements are able to aid the early detection of mild cognitive impairment and ultimately Alzheimer's disease. Saccadic eye movements, so fast eye movements characteristics, have been well described in Alzheimer's disease for many years. More recently, mild cognitive impairment, specifically differences between amnesiac and non-amnesiac mild cognitive impaired patients, have shown that amnesiac patients tend to behave in a similar way to mild Alzheimer's disease patients, which potentially provides a biomarker for the development of Alzheimer's disease. Optical coherence tomography was in the news quite a lot over the last 15 years with respect to measures of retinal nerve fibre layer being potential biomarkers for the development of the disease, and there's been a few systematic reviews in relation to looking at the feasibility and the evidence as to whether this could be a potential technology that could aid early diagnosis. But also, Routine visual function assessments of contrast sensitivity, visual acuity, and binocular functions have also been shown to be reduced in these patients. To our knowledge, there's no comprehensive study that's looked at eye movements, visual function, and anatomical changes in Alzheimer's disease or mild cognitive impaired patients. And this study will be a case-controlled study that will look at those main outcomes in both patients with a diagnosis of mild cognitive impairment and patients with mild decline Alzheimer's disease, as well as against age-matched controls. And the main outcomes will be saccadic eye movements, retinal structure using OCT, and visual function assessment. The potential benefits of this project lie in really the ability of saccadic eye movements, visual function, and retinal structures to potentially provide a cheap and non-invasive biomarker for the development of Alzheimer's disease in patients. In particular, the saccadimeter, which is a portable form of quantitative assessment of eye movements that you can see in the photograph here, has meant that assessment of these fast eye movements and quantification of those has been made that much more easier. These can be taken into clinics, they can be done at the bedside, and they don't require any specialist training in order to be able to measure the parameters of saccadic eye movements. And these may well help to address health inequalities in this group of patients. If these tests or these characteristics that can be obtained from these tests can be identified in, for example, routine eye examinations at the optometrist in the high street, where most elderly patients will go at least every 2 years to have their eyes checked, then it could potentially identify the development of the disease earlier in patients where they would normally not present to maybe their GP much further down the line when symptoms have become a problem and that started to affect them in their daily lives. So I'll be happy to answer any questions in the next part of this meeting today. I've left my email address there for you if anybody would like to get in touch. Thank you.
Okay, everyone. So now we're going to be moving into some breakout rooms. Now, in these breakout rooms, you would be given the opportunity to discuss 3 presentations by Nadia, Joe, and Craig. They will be in these rooms with you, and you can discuss, you can give them feedback as well. This will be breakout room 1. So Nadia is going to be in this particular room. Breakout room 2 and breakout room 3, the links are in the chat. Can I ask you, basically the way it was going to work is that you are going to be in the breakout rooms for about 8 minutes, after which, after 8 minutes, you would be given a choice of staying where you are or moving to another room. And after a total of 16 minutes, we will reconvene into this room. If you do get lost, please go back to the original email and it'll basically bring you back to this particular room. So you should not get lost at any point of time. So. Yep.
It's easy to do. Even I've managed it. You just need to go onto the chat and then click on the room that you want to join, and then just click the red button that comes up in front of you.
Yeah. So yeah, we would have people in the different rooms to help out. So please move now. Okay. I'm just going to put in the breakout rooms again if anyone's struggling. Okay, so does anyone have any questions for Nadia based on her presentation or any feedback? Anything? Nadia, would there be anything you'd like to add to what you presented today, just to kind of get the conversation going? Oh, sorry, no one can mute. I'm sorry. Apologies. There we go. I do apologize about that. There you can.
Thanks, Pallavi. Yeah, I was trying to unmute and couldn't. But thank you to everyone for staying here to discuss it. I suppose I can just throw out a few questions, really. I know I've spoken to some of you already through some other platforms about some of the ideas that come up around who are really the vulnerable people, the seldom heard people to focus on, and so it has been moving forward. I've got some very sort of more I've got some specific questions and some more general questions. So firstly, in terms of more general questions, I'm really keen to hear any views on projects that you might be involved in which involve ethnic minorities, and what, you know, some of the difficulties you have with engaging them. I would also like to hear about, you know, if any of you find there are specific techniques that are good for engaging people, and things that are quite simple, because I think I've had a lot of feedback and been trying to bring a lot of it together. Sort of, do we have a psychological approach to training someone in the community to deliver a specific kind of psychological intervention to help with motivation, or is it actually a lot more practical, where you just have to go and find these people and engage them through trust and you know, community connectedness, really? And so really some views on that. I see Steph, you have your hand up.
I think it's around community connectors, community navigators. I think I work with, in Knowsley we have a small charity called Share Knowsley that supports all asylum seekers or political refugees or resettlement families within Knowsley, and they try and link up with community volunteers to sort of make them welcome within the community and try and engage them in volunteering roles such as green environmental projects or community gardens, or ensure that they're aware of where the local food hub is or food bank, or other opportunities to volunteer, whether it be woodland walks and things like that. So what we do is we have a bit of a buddy system going on, which is very new, and we sort of support them to sort of access and welcome them to community green spaces, involve them in community planning for the yearly planning of our community garden, and also buddying them up with other people who might live in their tower block or in their area where they live. Or we have a wider environmental project called Northwest in Bloom, and that's a whole estate project. So we try and encourage them to come out, meet neighbours, meet friends, and also work together with other asylum seekers or resettlement families to sort of put together a document that is suitable for all, whether they may be there for 3 weeks, three days. It just gives them a program of what's there in their area, whether it be the local church, the nearest mosque, things like that. So it makes them part of our community, but we work with them and link up with them as buddies. And we might have a WhatsApp group, or we might have a weekly conversation or a weekly visit. Pre-COVID, it was maybe chat over a coffee in the local community hub or community centre. So it works well in Stockbridge. It's fairly new off the ground, but there is a couple of people that have linked in really, really well with resettlement families and political refugees, and a couple of the new asylum resettlement people within our community. So the community is warm and welcoming and embracing, but we do work with agencies that support them in a wider context to ensure that we've got DBSs, we're following the guidance of sort of confidentiality and safeguarding and things like that, but it works extremely well. Slow off the ground, but it's going very well.
Yeah, that's great. Thank you, Steph. Dorcas?
I think you mentioned about breaking the barriers, isn't it? And motivating people. I think to start with is that we need to identify why the BAME community having mental health issue is a taboo. That's one thing we need to break down. And then we need to look at the community itself, the community activists, like Steph has said in our own area. You find out there are a lot of community activists that belong to either the mosque or belong to the church or belong to the community. And we need to identify those, maybe through the public advisors, to help you to get the community view. A lot of research has been done, qualitative, asking questions within the community. Why don't you access social prescribing? Why don't you go to a gym? You understand? So I think that's what we need to look at as you're looking for advisors to help you to do that. But you will find we all belong to different groups. And once you get your group sorted and you can have a focus group of different community and you send them out there to help you.
Yeah, that's a very good good thought. And we've had a few focus groups, but I quite agree that beyond just having public advisors, there's a need to have much broader focus groups and a qualitative evaluation of all these community activists' views. Thank you. Yeah. Paul?
Yeah, just want to make a quick point really, just about vulnerability. So obviously, traditionally probably we've got some people in the next couple of months that are going to be vulnerable that maybe haven't always been. Thinking of people that are kind of dropping out of furlough and becoming somebody that's got needs straight away when they historically have never had those type of needs. So maybe kind of looking for the next few months around kind of vulnerability might be something that we need to consider, as well as kind of groups of people to reach out to. It's those people that are kind of dropping into that vulnerable category that maybe traditionally haven't always been.
Absolutely, yeah, you're quite right, and especially with the current issues with COVID and so on. I realize everyone can now change rooms, so I think it was just a brief chat, but as people are changing rooms, because I'm staying here, I'm happy for the conversation to continue if you don't want to move rooms. But for whoever wants to move, of course, please feel free to. Did I see Andrew had his hand up? Andrew Riley, is that right? Oh no, you were just scratching your head or something, sorry. I suppose a more basic thing is whether people here feel that actually the idea of bringing in some sort of motivational intervention, whether that is necessary or should the focus be on something else to reach the seldom heard. And from discussing already with quite a few community groups there, I'm often finding that people say, well, we always have the usual suspects coming along. We are open to the most vulnerable and those who need us most, but it's always the same people who keep returning. And yes, they are vulnerable, but we seem to, there's a whole load of people we can't get. So that's what the sort of focus of this is. But if you feel there's a different approach to doing it, please, happy to hear your views. There's a little bit of tapping from someone in the background.
If we're looking at social prescribing,
yes,
as you mentioned, as an intervention, the other thing that came up at the patient participation group is And is it going to be resourced? Somebody was saying, if they asked me to go to a swimming to get better, and I haven't got money to pay, what do I do? You understand? So that's another way you need to look at. Will it be resourced? If you have this intervention ready, if people are unemployed and they need to pay to go for swimming, they might not be able to pay for it. So when you are looking at social prescribing, you need to see with the GPs. You know, some will be free with, if you go to the trainers, they can make it free, because I've gone to the escaping exercises by going through the trainers. So that would be free. So there are other ways. So you need to look at that as well.
Yes, and that's a very good point, and often a real sticking point. And there are some projects that sort of manage to map community resources and mention whether they're paying or not paying and what the distance is. And so that is certainly something we should look at. You're right, yeah. So, and Steph is saying it's a community within the community you need to reach. Yes, so good point. It's the sort of, yeah, those who are just not accessing there. So I'm aware that some other people have joined us as well. So we've just been continuing the conversation from the last round, where I was just asking generally whether people here felt, firstly, whether there's a good justification for having these a potential bolt-on motivational intervention to help really access those who don't reach those services and who are not heard. And within minority ethnic groups, which is going to be the focus, you know, whether there are ways of doing that you're aware of. And also if you think there are other ways other than through kind of psychological interventions. And I gave a few examples of drawing people in from, you know, reaching out to them. How do you reach out to these people and how do you find them is still a big question for me, basically. Because even some of the community groups don't necessarily know where those people are who are not accessing their service. So any further thoughts on that?
Nadja, could I just come here? It's Saika.
Hi, Saika. Yes.
Yeah, thank you. I know I had involved in the focus group before, but we haven't heard from you. So I was wondering what's going on, but hopefully we will be involved at some stage.
Yes.
I totally agree with Dorcas that we have to do the breaking the barriers. Doesn't matter it's cultural, religious, or any types of barriers. It can be language barrier. It can be just male or female barriers. So these are the barriers which we have to break to reach to those seldom heard voices. And if we cannot reach to those communities, we cannot collect data. And to reach to them, I think through faith, through community connectors, and sometimes it's even better through public advisors because of the language barrier, because of the trust. Maybe people can express themselves to their friends and family rather than to somebody coming outside. So I just wanted to mention this, that through faith, community connectors, and specifically when it comes to trust and stuff like that, sometimes even the community connectors can't do this trick. Honestly, it's the public who raise the awareness within the community, and they make sure you are safe, you will be heard, and you can make a big difference to the research.
So thank you, Saika. Yes, and to come back on that, I think that's absolutely right. And the issue of trust has come up as a really, really strong issue and barrier. And that's also why we're thinking, you know, locating it within the community is a good idea within trusted partners. And having seen a lot of qualitative work and other qualitative work I've been involved in separately, there's quite a lot of lack of trust and in the health services, and feeling of lack of support and feeling of lack of cultural competency, etc. So that is one of the main ways, as you say, we're trying to overcome that barrier to go through. These demonstration sites have been chosen as being the community, you know, projects really. I'm aware we have just 1 minute left before we all join back into the main room. And to come back also, Saika, and to others who are here, whom I know have already participated quite a lot in some of these conversations. The reason for the delay in getting back is that I'm trying to apply for some funding for some of the public advisors, and before I know exactly how many I can have, I can't confirm exactly with you who's on board. But I think, like Dorcas was saying, I'd quite like to have sort of the public advisors, but also have several focus groups more widely and more specifically than these more sort of quick, rapid views and gatherings.
Thank you.
Yeah, in the final, I guess, final 30 seconds or so, I mean, does anyone have any views on, you know, whether this is something that you feel should change in some way, or whether there is general support for this idea and for involving ARC public advisors, you know, in this?
You have to involve the public advisors in this, because we're here to support you, isn't it? And to help you with the designing, and to help you to reach the community. And if you look at the public advisors, they're word of knowledge, and they come from different groups. Stephanie from Knowsley, me from Centra. So you need to use them, not just the two you're going to have, but others that might have point of view.
Yeah. And there's some useful comments here in the, I'm seeing in the chat also, about alternative ways of connecting, also thinking of Facebook groups, etc., which I completely take on board, Antoinette. And so thank you. I think we're coming back to the main meeting now.
So thanks everyone. What we'll now ask, I think, is for a very quick summary from what came out of those meetings. Is that right, Pallavi? And then we'll move on to some voting just to finish off. So if you remember, the voting is also from the presentations that you saw earlier. And yes, Nadia, if you want to go first, on you go.
Hi, thank you. Yeah. So from our group, we had very useful discussions. There was support there definitely for the idea of motivating those who least access the services for social prescribing and well-being, and some very useful examples of where that's being used through things like Buddy System in Stockbridge, and opportunities for volunteering and ways of sort of empowering and engaging people in those decisions. That's working well, and highlighting the need to really think of the newly vulnerable people who might not have been vulnerable before, like people who come off furlough, thinking also very clearly about some of the barriers. So there's language and gender barriers, and how to overcome trust barriers, and also barriers of resources, because a lot of well-being activities might be paid, and how they would how you could find more easily which are free for these people. And also the idea that it's very important to still do a lot more scoping with a lot more people who are community activists in this area, to have as many views as possible in helping co-develop this intervention.
Thank you very much, Nadia. Which of you would like to go next? Joe?
Yeah, I'm happy to go next. So we had a really good discussion about mainly focused around health inequalities aspects of it, which is what I was asking for, so that's great. So we talked about not necessarily presuming that people wouldn't get involved because of COVID and it being online, but that there were some barriers that we needed to overcome in terms of advertising it and not making it seem like it's an expensive thing to do in terms of going low carb, and that there would, but with that does come some realities that, you know, people who are relying on food banks and don't have as much choice over the kind of food that they're getting, it is going to be difficult for them to be involved. And also that a lot of people who are on like paid as you go broadband use, it would be quite expensive. We might need to look at getting some funding in place to support people who are doing that. It also had some just good positive stories of people managing to maintain online, maintain their communities online during this time, which gives me some hope. So thank you very much.
Yeah. Finally.
Yeah. So had some really good discussions about the potential impact of the early diagnosis of Alzheimer's on patients' quality of life, and it being, you know, quite a useful thing to have that early diagnosis, and also some good feedback in respect of the fact that you know, a new kind of classification for diagnosis coming up as a preclinical diagnosis based on biomarkers, so it would fit in, this kind of a project would kind of fit in with that, and got some good advice as well about my main concern was getting in contact with patients and that kind of thing. So I've got some really good links to make now with respect to you know, getting in to speak to patients and have involvement with them and get patients recruited to the project. So yeah.
Thank you very much. So now we're going to move to being able to click on your link to the voting. It shouldn't take more than a few minutes to do the voting, and we'll be led through that, and then we'll just come back very briefly to end the meeting. So Pallavi,
okay. Yep, sure. Okay, so we're going to use some voting again, same link. The first one is based on Nadia's presentation, and basically the question is, again, how would you prioritize this outline proposal for the ARC? Sorry, I do apologize. I know that. So we've got about 8% low, 31% medium, and 62% high. The next one, sorry, I'm having some problem with my. Can you see the next one?
Not yet. We did for a second. It's gone again.
Sorry, I do apologize.
It was working so well before.
I know. Cool. Just gonna. Okay. Sorry, bear with me.
It's all right, don't worry. Yeah.
Okay.
And don't forget, we've got to go back to the ones that were on earlier.
We did those, didn't we?
No, remember we said we'd do them at the end, the 4 presentations.
We did them. Oh. Okay. Yeah. We did those, Mark. Yeah.
Sorry, you're right. No, you're right. Actually,
don't worry.
You're right. We did them at the end, didn't we?
Yeah. So we've got about 58% yes and 42% no. The next one. Sorry, my screen is not working, so I'm just using the actual So we're going to go next to Joe's, and that's the low carbohydrate program. Hoping you can see that.
Not yet.
It should come up.
There we go.
Yep. Okay. So we got about 4% low, 29% medium, and the rest is high. Move on to the next one.
Yep.
Yep. Okay, great. It's about 50%. And the final one is Craig's, and I'm just going to go into that. Eye movements and visual function. About 17% low, about 37% medium, 37% high, and the rest is not priority. And finally, we have, would you be interested in participating in this project? Sorry.
There we go. That's come up now.
Apologies.
The saving grace is that we can't see you sweating.
No, you can't. You've got about 20% yes and 80% no on that. Okay, brilliant. So let's just come back here. So that's about it. It's a bit of a rush in the end.
To bring us back to the main. Or can't you do that?
So I'll just stop sharing for now.
There we go.
Yeah.
So is that the voting done? Thank you very much. I see we had quite a good group of you stayed to the bitter end after we'd finished. Is that a hand up, Jane? Do you want to say something? Oh, you've got a hand waving. Is that a waving goodbye hand, Jane?
Me? A hand?
Yes, you've got a hand up.
Really?
Yeah,
oh, I didn't mean to.
Oh, it's my hand, right? Okay. It's my mouse. Sorry. Never mind. The technology, hey. So thank you very much. It's been I hope you agree, it's been a really interesting meeting. There were a few gremlins, but surprisingly few, and we kept to time actually a bit better than I was expecting we might. So thank you very much for your time and your input and your energy